Today we will be discussing about pharmacological management after CABG procedure. So mainly we will focus upon the secondary prevention of cardiovascular events after CABG. We all know that this procedure is a life-saving procedure. So it is our duty to follow up the individuals with proper and adequate care in terms of pharmacotherapy as a secondary prevention measure. So our aim should be to maintain the graft patency, also to prevent future cardiovascular events. With this, we can improve long-term survival of the patients who have undergone CABG. Why is it so important to discuss about the secondary prevention? Is because those individuals who have had CABG procedure are considered as very high risk ASCVD category individuals. So there will be again highest risk of atherosclerotic cardiovascular event in these individuals. That's why all the surgical revascularizations must be followed by aggressive and permanent pharmacological management without fail. So the first point to remember is that this pharmacotherapy will be a lifelong therapy. We'll discuss it one by one. First, coming to the antiplatelets. This is the most important and crucial pharmacological therapy in managing and in keeping the graft patent. That's why we call it as the patency shield. So the main therapy here will be aspirin, as we all know. But here are the important points about it. We have to start aspirin within 6 hours post procedure, and the dosing should be 75 to 100 milligram every day, and it should be continued indefinitely. As mentioned, it is a lifelong therapy and it will help in improving the graft patency as well as it will reduce future cardiovascular events. So these are the benefits of antiplatelet therapy. Whereas when it comes to dual antiplatelet therapy, DAPT, here based on the patient's profile we have to decide. For example, if the patient is having ACS, acute coronary syndrome, then it is mandatory to prescribe dual antiplatelets for 12 months. After 12 months, we can change it to single antiplatelet therapy. So who are those patients? Mainly the one who have presented for unstable angina or N-STEMI or STEMI category, ST elevation MI. Mainly those individuals who are having vulnerable and ruptured plaque. Whereas in path B, these are the individuals who have stable coronary artery disease. This is nothing but stable angina, what we say. Stable angina, in which there will be only narrowing of the blood vessels without actual blockage, and the patient will be getting exertional angina and they will be feeling better on taking rest. So if these are the individuals, in them we can consider dual antiplatelet therapy only if there is low risk of bleeding. Otherwise, dual antiplatelet therapy is not required in this group of individuals for the maintenance of graft patency. So the overall point about antiplatelets is, first decide the patient's profile, whether they are having ACS or stable angina. If there is stable angina, we can maintain the graft patency with single antiplatelet therapy only. Even in those individuals, if there is very lesser risk of bleeding, we can give dual antiplatelets again for 12 months. In all other individuals who have undergone CABG procedure, we can go ahead with 12 months of DAPT, then we can change it to single antiplatelet therapy. And preferably, we will go ahead with aspirin, and these are some important points which I have discussed about aspirin. Coming to the lipid management, remember the target is very narrow. In the sense, ideally we have to keep it below 55 or minimum we have to get it down below 70. So for that, what we can start ahead with is high intensity statin. So for example, Atorva of 40 to 80 mg or rosuvastatin of 10 to 20 mg should be started without fail. Then if the target is not reached, we can add on with ezetimibe or PCSK9 inhibitor stepwise. And if required specifically to target triglycerides, we can utilize icosapent-ethyl as an additional drug. Overall point is aggressive lipid lowering strategy is very important in CABG patients because they are considered as very high risk ASCVD category patients. So that is about lipid. Then comes some of the hemodynamic controls and target pressures. Remember, the blood pressure should be maintained below 130/80. So we can utilize few of the medications, preferably calcium channel blockers like amlodipine, nifedipine, cilnidipine, etc. for the first 1 year post-operatively, because these calcium channel blockers will help to prevent radial artery graft spasm. So by the relaxation of the artery, these will help in preventing the arterial spasm. That's why for the first 1 year for BP maintenance, we have to utilize dihydropyridine calcium channel blockers. Also, if there are some indications like prior history of myocardial infarction or diabetes, LV dysfunction, hypertension, heart failure, all these things, in that case, we should choose AC inhibitor or ARB as antihypertensive agent. And as I mentioned in one of my previous videos, the combination therapy is always best. Coming to the fourth pharmacological therapy, that is nothing but beta blocker. Remember, if the patient has got MI and we are planning for CABG procedure, so if the individual is not already on beta blocker, do not initiate beta blocker in all cases. Suppose you find that particular individual as having the risk of atrial fibrillation or some tachyarrhythmias, then we can start beta blockers pre-operatively as well. And for post-operative state, we have to start this particular therapy, especially if there is reduced left ventricular ejection fraction or if there is evidence of heart failure. But once the individual comes out of this acute crisis, then we can add on with beta blocker, because the benefits with beta blocker are it will reduce the rate of atrial fibrillation and the future risk of MI. Overall, there will be mortality benefit with beta blockers. So I hope the point is very clear regarding the usage of beta blockers. There is high risk of arrhythmias, especially tachyarrhythmias. For example, in anterior wall MI and all, we can start with beta blocker pre-operatively and we have to continue it post-operatively as well. Suppose there is no such risk and if the individual is not already taking beta blocker, no need to start pre-operatively. We can wait, and after the procedure, based on the ejection fraction and heart failure category, we can start the beta blocker. And once all these things are done, we will be assessing the ejection fraction and the heart failure management has to be undertaken, especially if there is reduced EF. Then we have to start with GDMT and try to achieve the optimal dosage. So in GDMT, there are 4 pillars, as we all know. It can be remembered, as I always mention, an acronym by BAMS. So B stands for beta blockers, A is AC inhibitor or ARB or ARNI, M is MRS, and S stands for SGLT2 inhibitors. And if the EF is reduced, we can choose ICD based on the proper indications. Probably you all might be knowing the role of ICD, especially when the EF is less than 35%. Patient should be in sinus rhythm and there should be widened QRS complex, wide QRS complex, more than 120 milliseconds. So these are some indications to consider ICD, and that has to be placed after 90 days of the revascularization procedure. Regarding metabolic optimization, especially nowadays, these two group of drugs are in talk, SGLT2 inhibitors and GLP-1 receptor agonists. Overall, regarding metabolic health, remember, hypoglycemia should be avoided at any cost because that will put unnecessary load on the cardia. And regarding glycemic targets, we all know we can utilize these group of medications or any other anti-diabetic medications to reach the goal. But to talk about these two group of drugs, remember, SGLT2 inhibitors are proven to be beneficial in relation with cardiovascular health. So it will reduce cardiovascular mortality, heart failure related hospitalizations, and even CKD progressions. And these benefits are there independent of HbA1c levels. But suppose the individual is already on this particular group of medications, just hold on this drug 3 days prior to the procedure. Coming to GLP-1 receptor agonists, the newer molecules have shown to reduce the MACE, major adverse cardiovascular events, and support active weight loss, and it is highly beneficial in patients with multiple comorbidities related to atherosclerosis. And if the individual is already on this particular group of drugs, we have to withhold minimum 7 days prior to the procedure. Next, we will discuss about the anticoagulation. Remember a baseline rule, anticoagulation is not routinely indicated after CABG. So remember, antiplatelets are compulsory but not anticoagulants. So again, for anticoagulation therapy, we should look for post-operative atrial fibrillation, and suppose the atrial fibrillation related stroke risk is higher, then only we will consider oral anticoagulants. Hope you all know the CABG score. So based on that, if the individual is male, if the score comes to be more than 2, or in females more than 3, they will be at higher risk of getting stroke related to atrial fibrillation. So those individuals will get benefit from oral anticoagulants. Otherwise, in routine, it is not recommended. So just to summarize, in and around the procedure of CABG, remember, withhold SGLT2 inhibitors 3 days prior. If the individual is on GLP-1, we have to ideally withhold it 7 days prior procedure. And regarding beta blocker, I hope it is very clear now. If there is no indication, no need to start preoperatively, and post-operatively within 6 hours start aspirin. And once the procedure is done, what will be the chronology of pharmacotherapy? Remember, after 90 days of procedure, if indicated, we have to advise for ICD placement. And after 1 year, 2 major changes are going to happen. One, if we have started on calcium channel blockers, we can stop it. And if the individual is on dual antiplatelets, we can shift it to single antiplatelet therapy for lifelong. And there are some medications which the individual has to take for life. For example, aspirin. Lipid management should be in the target range, that is ideally below 55, and beta blockers in indicated cases has to be continued for lifelong, and metabolic management and BP control should be below 130/80. So the overall interconnected pharmacological intervention is very, very important in secondary prevention after CABG, which will improve survival, and there will be fewer cardiovascular adverse events and improved graft patency, which should be our aim in every individual who has undergone CABG. Thank you so much. Share this video among all the internal medicine and cardiology residents so that we will be able to justify and contribute in the successful outcome of a life-saving procedure such as CABG.